terms of sending all the specimens that are available. You should be actively looking for the specimen that you can send. For example, this may look like everything respiratory, but you may have a cervical lymph node here, but the FNSE can give you a diagnosis. So look for those all possibilities where specimen can be sent. A specimen like sputum is easy to send, but in child who has this, if available, furthermore you can send something like bronchial lavage. All those specimens come as a possibility. So clinically, you have considered a possibility, and all available specimens should be sent.
Okay, so we understand that we should send the specimens, and so can you just take us through this concept which which we have been talking about for a long time, which is known as a universal DST, and which will help everyone to understand, why you need to do a test up front.
So yes, as you would know that if the patient has UTI, you will, whenever you are starting treatment, you will upfront send a culture so that when the reports come, you will have to tweak your antibiotics accordingly. We were far away from that till a few years back, because we did not have a test which will rapidly give us those results. So nowadays, we have a test which gives you results technically within 2 hours, but practically maybe in 1 or 2 days or 3 days, you will have those tests which will at least tell you that this is TB. Not just that, it will tell you whether it is resistant, it is rifampicin resistant or not. So this is the day, and then you have other tests also which give you this, whether the bug is resistant to which drugs. So nowadays, the emphasis is not just on detecting TB. We are trying to find out upfront, because we have tests available, whether it is resistant to one of those first line drugs or no. That is how we begin with. So all of these.
So all patients should have a microbiological diagnosis, or you should attempt a microbiological diagnosis, and we have to look for at least resistance to rifampicin, which is thought to be the key drug, at least rifampicin initially, right? Okay, so that's an important message, that you need to look at both of these things, right? So Dr. Kamal, this is the algorithm, and I have highlighted this part of the algorithm which this child falls into. So just can you take us through briefly into this limb of the algorithm where the child falls, so the child hasn't improved with the course of antibiotics?
So what we see here is, if you look at the green boxes, so the X-ray is not normal. So the topmost boxes where you think consider the criteria for presumptive TB, they have been fulfilled. So let's come down to that. The green box here, we have done a chest X-ray. There are 3 options. Either the X-ray is normal, which is not the case here. On the extreme left, we have X-ray is highly suggestive, which means miliary, a chronic fibrocavitary, or a lymph node. It's not that also. So we have X-ray which shows some consolidation or some infiltrates, which is a non-specific shadow for us. We have gone through that grind where you will give set of antibiotics. If it doesn't respond, then we come further. There are persistent shadows. So despite appropriate antibiotics, the shadows are persisting. In this case, you will send these specimens, whichever are available to us. It could be a sputum which has to be sent, or if not available, an induced sputum, if not available, gastric aspirate, and then depending on whatever facilities you have, bronchoscopic lavage or what else could also be sent. In this case, if it turns out to be NAT positive, the issue is more or less solved, because it will tell you about whether the MTB is detected or not, rifampicin resistance is not. If it is not NAT positive, then look for other sites. TB is not something that if it is pulmonary, it will be in lungs only. It is at multiple places, but the window is probably opening in lungs alone. But if you are actively looking at it, probably you will find another site where you can actually get a microbiological evidence. So actively look for lymph nodes. Maybe a abdominal lymph node is so big that you can do a tap from there, not here. So that investigation can be done. So look for other sites where you can investigate, and consider repeat NAT more so if you do not have evidence to suspect multi-drug resistance on history in such case. In that case, a repeat NAT can be done, but if there is otherwise the indicators also, then this alone will be enough. Alternative samples, as we have written, BAL will all be seen, and if suppose at the end of it, you are not able to get to a diagnosis, then you can always seek help from an expert who is regularly seeing such kind of patients, if you are not regularly seeing such kind of patients. And if the NAT is positive, of course, the problem is solved. If the NAT is negative or repeated test not indicated or feasible, look for alternative diagnosis also.
Yeah, so we went through this algorithm and the sputums were negative, but it was a non-specific shadow. Right, so Dr. Kamal already has answered this question that, do you go ahead and do further tests? So again, just to reiterate, if you have the facilities, then doing a sample or a further sampling is something which should be tried, because you should look for a microbiology and satisfy the UDST concept. If facilities are not available and it is not a high risk case, then you might go on to treat this child if the facilities are not available. But if you have a situation when if this can be a probable DR, which means previously treated for tuberculosis, already on treatment with poor response, an HIV patient, or a contact with an MDR, then in that situation you cannot put this child on treatment without microbiological diagnosis, and doing a further sampling is mandatory. So the next question is that, with this child who doesn't have any of these risk factors, can this still be an MDR?
Yes, of course, it can still be a drug-resistant TB because you still can have a drug resistance there without those indicators. So that's why we said if you have the facility, you have the capability, try your best to send all specimens, try and investigate that. But at the end of it, suppose there is no history, the history is not suggesting a possibility of a drug-resistant TB, you may very well start with the first-line drugs that we have. But then then you have to closely monitor this child. If the child starts responding well and there is appropriate response in next 7, 10 days, 15 days, you can very well be assured probably this is all drug sensitive and you can keep treating that. But then again, if it doesn't respond, then you do not leave it there. If you have started empirical anti-tubercular therapy, the onus is on you that you monitor this child well, and if on follow-up you find that he's not responding the way you want him to be, then you have to again investigate and look for other possibilities.
Yeah. So uh, so we are talking about, sampling methods, and we are also saying that, a lot of people not able to send the samples. So Dr. Singh, can you help us understand what are the sampling methods which can be used in children, and how will you go about it?
You see, few words are like a red flag to a bull. You show a red sheet to the bull and the bull starts charging at you. So you say sputum to a pediatrician, they start charging at you. बच्चों में sputum कहाँ होता है बेकार sputum भी हुआ. फिर दूसरी तरफ हम ही लोग कहते हैं कि the pediatrics is from 0 to 18. So are we talking of only primary complex? Are we only talking of younger children who are not able to expectorate? You also have older children who can expectorate. So sputum remains a specimen, an important pulmonary TB specimen for pediatric TB. It depends on what age group it is. Younger child who has protective cough, then instead of sputum which they are not able to expectorate, you can either collect it, overnight collection into the stomach is happening, you take out as a gastric acid. That is a second method. Or you can do a induced sputum. Okay, you induce the sputum and do a nasopharyngeal aspiration using a ball suction. When you put that nasopharyngeal aspirate, like D. Willis or any mucus trap which we use in our nurseries, it will tickle the throat. When it tickles the throat, child coughs, whatever secretions are loosened, they come up. Before the child can swallow, they are trapped by you in that mucus trap. And that's how people have used this without induction, then it is called nasopharyngeal aspirate. They have used it with induction, it is called induced sputum. Effectively the same. You are trying to catch this specimen before it is swallowed by this. So these are important ways we can reach a respiratory specimen, respiratory specimen for pulmonary TB in pediatrics. What is important is that TB, while may show a disease or a symptoms or a window in a given system, it may not restrict to that. So you could have a situation which we alluded to earlier also, that child comes to you with pulmonary TB, you have seen an X-ray. But if you find out, you may get a lymph node somewhere where you are able to get an aspirate. Ultimately, you have to get a final diagnosis as to whether it is MTB and whether that MTB is sensitive or not. So the alternative specimens can go. Vice versa is also true. We do not investigate many times our lymph nodes whether they have chest lesion or someone who has abdominal or a TBM. 20% of microbiological diagnosis in TBM is added by respiratory specimens and not by CSS specimens. So it's a lot of time, it's a respiratory specimen for an evidently extrapulmonary disease which will come. So that's NS. Then comes the role of alternative specimens. Here is a child where you are thinking in terms of drug resistance, and it's empiric, it's very important for us to have a specimen. You have already treated one, child is not responding. Those are the situations where you will go as invasive as required. In the context of pulmonary TB, it would mean do a bronchoscopy, bronchoalveolar lavage. It may, if there are lymph nodes, you may have to do a FNAC from intrathoracic lymph nodes. Whether it is done by endobronchial ultrasound, which will be possible in an older child because still the bronchoscope is for endobronchial ultrasound, that the size is big. People have even used transesophageal. So you use the same endobronchial ultrasound into the esophagus, and if there is a subcarinal node, you can take an FNAC from there. So all this is possible whether you do that or tissue biopsies. So many a time when you send to your surgical friends in abdomen, which could be a Cox abdomen, and they open up, please do advise them to take a sample out of not send it in formalin. Send it in saline for culture as well as for CB-NAT. And that's something very important, that tissue biopsies are also amenable to the NAT. This takes us little beyond respiratory specimen, which is important. Now the other thing which is coming a lot in literature is stool, urine. What to do with them? Stool is again like swallowed sputum. You catch it in the